Friends, let's learn about hyperkalemia. This is very important topic for any exam, including medicine also and surgery also, okay, and clinical practice also. So, hyperkalemia is defined as potassium level more than 5 millimole per liter. So, more than 5, okay. Then there is a term called dangerous hyperkalemia. So, when the potassium level is more than 6 to 7, okay, it's indicated by T wave higher than R wave, okay. The most common cause of hyperkalemia is renal failure in hospitalized patient, okay. So this can be asked in MCQ, okay. So transport of potassium is passive, but transport of sodium requires sugar. So P for P and S for S, that is energy, okay. Then causes of severe hyperkalemia, okay. So they may ask what are the causes of severe hyperkalemia. The succinylcholine, prolonged bed rest, neurologic denervation syndrome, then severe burn, direct muscle trauma, and rhabdomyolysis. The important ones are rhabdomyolysis, severe burn, prolonged bed rest, and succinylcholine. Many times asked, okay. Even hyperglycemia or IV menthol can raise the potassium, okay. Then renal insufficiency, potassium sparing diuretics and angiotensin converting enzyme inhibitors and NSAID also can cause hyperkalemia, but these are the causes of severe hyperkalemia, okay. Then drug affecting potassium excretion like trimethoprim, spironolactone, beta blocker, cyclosporin and tacrolimus, that can also cause hyperkalemia, okay. Important ones are spironolactone, beta blocker, okay. So there is a ischemia, a reperfusion injury associated with hyperkalemia from 4 to 6 hours. So usually it is recommended administer bicarbonate before reperfusion. So okay, so bicarbonate administration before reperfusion, okay. So what are the symptoms of hyperkalemia? The primarily clinical problem with hyperkalemia is cardiac arrhythmia. Many times asked and important for clinical practice also, okay. And the GI symptoms include nausea, vomiting, intestinal colic and diarrhea, okay. The neuromuscular symptoms are weakness of ascending paralysis to respiratory failure, okay. Now comes to the ECG changes, many times asked, okay. So ECG changes are eventually lead to hemodynamic symptoms of arrhythmia and cardiac arrest. So ECG changes include high peak T wave, okay. These are the early change. Then wide QRS complex, then prolonged PR interval, okay. So remember high, wide, prolonged. There is only flat P wave. That's why I didn't highlight this one, okay. So flat P wave, rest all are high, wide, prolonged, okay. P for prolonged, PR interval, and there is one liner is sine wave formation, okay. That is sine wave formation, and features of ventricular fibrillation, okay. Now come to the treatment of hyperkalemia. So first line therapy is IV calcium can immediately reduce the risk of arrhythmia. So first line therapy is IV calcium, MCQ, okay. Now most effective in hyperkalemia with metabolic acidemia. When it's written metabolic acidemia, you will think of bicarbonate, okay. Bicarbonate, don't mark dialysis and all, okay. Hyperkalemia with metabolic acidemia, bicarbonate, okay. So, and what you can do for decrease extracellular potassium, so insulin and IV glucose infusion, okay. How they work? They increase sodium potassium ATPase activity, so it will decrease extracellular potassium level, okay. Then aldosterone deficiency with hyperkalemia, okay. Aldosterone deficiency with hyperkalemia, what you can do, mineralocorticoid drug you can use, okay, 9 alpha fludrocortisone, okay. This will increase the renal excretion of potassium. Not that important, that insulin one is important, okay. Okay, then hyperkalemia in acute renal failure. If you see the word renal failure, then you have to mark hemodialysis is the most reliable method, okay. Then in chronic hyperkalemia with renal dysfunction, sodium polystyrene sulfonate is given. It can be given rectally or orally, but rectal route is preferred. This will exchange the cation exchange agent that binds to potassium in the gut lumen, okay. So rectally administered binding resins are particularly effective because of colonic mucosa can excrete mucus with large amount of potassium. That's why rectally is preferred, okay. So these are the treatment of chronic hyperkalemia, okay. Okay. When ECG changes are present, calcium chloride or calcium gluconate, okay, 5 to 10 ml of 10% solution should be administered immediately to counter the myocardial effect of hyperkalemia, okay. So ECG, remember when it comes to ECG, C, so calcium, okay. It can be calcium chloride also and calcium gluconate also. So CG you can remember the calcium gluconate, okay. This is more frequently asked, that's why I am highlighting this. So if ECG, you have to remember the calcium gluconate, okay. Okay. So calcium infusion should be used cautiously in patient receiving digitalis because of digitalis toxicity, okay. Not that important, just remember, okay. So there is a table in Sabistion. So guidelines for treatment of adult patient with hyperkalemia. The first is you have to stop all the infusion of potassium, okay. Now is echocardiographic evidence of pending arrest. If you word see the pending arrest word see, you have to do like IV calcium salt, like 10% calcium chloride or sodium bicarbonate, okay. And if you see the word effect, so you have to give glucose infusion or you have to give immediate hemodialysis, okay. So ECG evidence of potassium effect, you have to do insulin and hemodialysis, okay. And if there is arrest, then you have to do calcium, okay, calcium salt in form of calcium chloride and calcium bicarbonate, okay. If there is no ECG changes, you can do that potassium binding resin with 20% sorbitol or promotion of renal chylauresis by loop diuretics. So diuretics and resins used in when there is no ECG changes. So here we can compare the hyperkalemia with the MI ECG changes. So in hyperkalemia, that in both T wave will be tall, but in hyperkalemia that T wave will be tall, narrow. You can see this narrow and symmetrical. These both are symmetrical. Okay. In acute MI, the T wave will be drop, but this will be asymmetrical and the base is broad. Okay. Okay. Then you can also use nebulized albuterol, so just to decrease the potassium level. So there is one more table in Schwartz. So treatment of symptomatic hyperkalemia. So they will ask what are the drug used for potassium removal, and we will give one extra drug from these three. Okay. So for potassium removal you can use K-exhalate, sorbitol, oral or rectal, and dialysis. These are for removal. Dialysis you can remove, sorbitol also for out, okay, and K-exhalate is the keys. So it will make the open the gate of potassium and it will make throw out. Okay. Then shift the potassium. This is many time asked. So shifting, for shifting you need the insulin in D5 solution. Okay. Generally we give 5 to 10 units, not that important. Okay, okay, and then sodium bicarbonate. Okay, and the if you have to counteract cardiac effect, the ECG again C for C. Okay, so that's it for hyperkalemia. Important point I just want to revise. Quick review. Definition of hyperkalemia: more than 5 millimole. Dangerous hyperkalemia when it is more than 6 to 7 millimole per liter. Most common cause of hyperkalemia is renal failure in hospitalized patient. Transport of potassium is passive and transport of sodium requires energy, that is sugar. Then causes of severe hyperkalemia, important ones are succinylcholine, prolonged bed rest, neurologic denervation syndrome, severe burn, and rhabdomyolysis. Okay. Then drug affecting potassium excretion are spironolactone, beta blocker, and tacrolimus. Okay. The symptom of hyperkalemia, the primary clinical symptom of hyperkalemia is cardiac arrhythmia. In neuromuscular, you will see ascending paralysis with respiratory failure. The important ECG changes are high peaked T wave, wide QRS complex, prolonged PR interval, and sine wave formation. In the treatment of hyperkalemia, the first line treatment is IV calcium. The hyperkalemia with metabolic acidemia. So in acidemia, you have to do bicarbonate therapy. Okay. Okay. Then in hyperkalemia with acute renal failure, patient you have to do hemodialysis. You see the word renal failure, hemodialysis. Okay. 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 So ECG changes present, you have to give calcium gluconate or calcium chloride. Okay. Okay. Then there is a ECG difference between hyperkalemia and MI. So that is the hyperkalemia will be symmetrical, MI will be asymmetrical. Okay. And there is a short treatment table, like potassium removal. We will use Kiexalate, sorbitol, and dialysis. Shifting of the potassium will be done by insulin or bicarbonate, and counteract cardiac effect by calcium gluconate. Thank you.